our April virtual hangout. And I hope everyone is ready to engage and chat. We've got two great speakers this evening. We're going to have really, I think, active conversation about this really important topic. So get your chats ready, get your questions ready.
Yeah.
We've got a busy April and May coming up. So we'll have Cameron pop on with us as well to share a little bit of what we have going on at Unite for Her.
Yeah, wonderful. And then just a reminder, you all know Zoom by now. So I'm not telling you anything new, but watch your chat for any questions. Please keep yourself on mute so we don't have any background noise. And this is, of course, as Erin said, we are recording it. So we will have everything up for you on our library in case you missed something or you want to get back to it. We find that to be just such a value to so many people. There's so much that we learn during this time, Erin, that I always find myself going back to saying, what did she say? Especially Dr. Mo, she gives us so much good information. As she
So
does.
much good information. And I know our team, we're always sharing the links depending on what topics come up in our conversations with our members. So it's really nice to be able to link out all of these different discussions and learnings that we've had over the past several years. So yeah, we definitely keep that library active.
Yeah. And then we of course want to let you know about some of the things that we have coming up in April. So if, as a reminder, we have an Ask the Experts coming up. It is Thursday, April the 25th at 1:00. It's always live. And we're going to be joined by Jill Meyer-Lippert of the Side Effect Support community. Jill will chat with Erin about the importance of oral health, especially as a part of a person's whole body wellness, which we've been learning a lot there in that area as well. We're really looking forward to that one.
Yeah, I'm really excited for that conversation. This is the first time we're having Jill on, and I just messaged her yesterday because I saw some new research that came out about a link with bacteria in the mouth to colon cancer. So we'll definitely be diving into that link with not only our community, but just cancer risk in general. So really great conversation to be had next week.
Yeah. And of course, we want to thank our sponsors, right? We can't do what we do without them. So a huge shout out for our presenting sponsors who are West and Merck and Daiichi Sankyo. And then, of course, our supporting sponsors, GSK and Lilly. We do 36 of these a year. We are grateful. We are honored to always bring top of mind subjects to you and the community of Unite for Her. And we can't do what we do without them. So a little shout out for our wonderful education sponsors.
Yeah, absolutely.
All right, shall we bring in Cameron?
Yeah, because we've got even more fun stuff to look forward to.
We do. Hi, everyone. Oh, it's so nice to be on with all of you and join this month's virtual hangout. April is, and everything that Sue and Erin rattled off, April is a very busy month, and we end with our Bloom Fashion Show. So this is our 12th annual Bloom Fashion Show. It is a day all about all of you, our community. So we love to take a moment and celebrate you and thank you and share our community's incredible and inspiring stories. So we have 15 models this year, one virtual from California. I was actually scrolling down to see. She tricked me. She was on last time, but she's not on this time, but that's okay. You'll just have to tune in to hear all about Maria and her journey out in California. So we have two ways or actually several ways you could join us at Bloom. If you are local to this area, it is at Drexel Brook, which is right outside of Philadelphia. You can join us in person. Tickets for that event are on sale through Sunday. So this Sunday is the last chance you can purchase in-person tickets. I think Erin might pop that link possibly into the chat. Already there, figured. Thank you, Erin. So that's the in-person. We also have the stream. So we will be live streaming our event. And that is right on our Bloom event page. So all of the information on Unite for Her's website, under events, under Bloom, that link for streaming, you can join us from anywhere and see all of our incredible models and hear from some of our sponsors as well. So because we could not do that event like all of these events too, we could not do that without our sponsors, our lead event sponsor, Daiichi Sankyo, again. So we couldn't, be more grateful for their support and all of our other sponsors that help us put on Bloom. So we have our streaming, we have our in-person that you can join us. But we also have some incredible grand prize raffles that you can share with your friends and family. We have 4 incredible prizes with that. One of them being an in-home cooking demonstration and dinner with Erin right there and her incredible culinary team. So there are vacations, there are shopping sprees, and you do not have to be present to win those grand prize raffles or local realistically either to win some of those grand prize raffles. So yes, thank you for allowing me to come on and share about this upcoming event. It is truly my favorite event that we do every year because it is all about our community and their stories. So I hope you can join us one way or another. And I appreciate Sue and Erin and all of you for allowing me to take a few minutes and share the goodness of Bloom with all of you.
Yeah, thank you, Cameron. And we have a pass model on our show with us tonight. She's smiling. Cynthia, she's like, oh, I can't believe you said that. But Cynthia's up there. She was our model. So it's always nice to have her there. She knows what it feels like to walk that runway. It was certainly a lovely event. And Cynthia, you were beautiful.
Yes.
So it's always good when we can see our community all coming together. And I have one more plug, Cameron. So, Dr. Mo has this amazing farm. It's Still Rise Farm. We have an event coming up, and that is going to be May the 4th, I think, right? May the 4th. So Dr. Mo, I put that in the chat. Please sign up. It is an incredible day. We partner with them, and to have this beautiful, her farm is amazing. She has this vision of bringing all of the knowledge that she knows and Unite for Her and some of the partners and nonprofits to bring this integrative care approach that we have a day of healing no matter what part of your treatment plan, diagnosis, path you are on. There is something for everyone, everything from fishing to massage to sexual health. Actually, where we met Dr. Gichuru, I was so impressed with her. So it's right there in the chat there, Still Rise Farms. You can see there, Dr. Monique Gary actually put that in there, and we hope to see you there as well. Always have a lot going on.
Mm-hmm.
Always.
It's free. And it's free. So yes, we do. We hope you
Even
enjoy.
better.
Yeah, even better. Yeah,
Mhm.
everything we do, Dr. Mo, Unite for Her is free. So I think our community knows that. I hope so.
Perfect.
Yeah. All right, Erin, are we ready to go?
Let's do this. We have great attendance tonight, and of
We
course
do. I have been
because
letting in a lot of folks as we were
I
chatting.
know.
Mm-hmm.
Love this. So let's bring on our guests, and I'll let you do the honors.
Yeah. So first we have Dr. Roseanne Gichuru, and Dr. Gichuru, thank you so much for joining. I was so impressed with you when I did meet you at Still Rise Farm, and just so grateful for everything that you do. A little bit of her background, and we realize that we are alumni from Westchester University together, but she obtained her undergraduate degree in cellular molecular biology and women's study from Westchester University. She received her medical degree from the Philadelphia College of Osteopathic Medicine and an MBA in healthcare management from St. Joe's University. Dr. Gichuru's mission is to provide high quality care to women in rural and underserved communities. One way she does this is by utilizing and embracing culturally centered and trauma-informed approaches in her interactions with our patients. So Dr. Gichuru, thank you. We love having you. And then, of course, Dr. Monique Gary, she is no stranger to Unite for Her. We are so grateful to have her as a trusted advisor. She comes on our show often. Dr. Mo, as everybody knows her, is a breast surgeon, educator, entrepreneur, media personality, farmer, philanthropist. You do so much. That's what I am so grateful when we ask you to come on here, that you do give your time to our community. We are forever grateful. She currently serves as the medical director of Grandview Health, Penn Cancer Network Cancer Program, where she also serves as the director of the breast program. Dr. Mo believes in the power of connection between body, mind, and spirit. That's how come our relationship is so in line and aligned with synergy that just allows people to do better, whole patient care, overall wellness, and is passionate about addressing the disparities in health outcomes for marginalized people. So please join me in welcoming our guests, Dr. Gichuru and Dr. Gary. Thanks for coming.
Thanks for having us.
You
Thank
got
you
it.
for having us. Appreciate the invite and love to meet other like-minded folks and to add and learn from these kind of spaces. Um, I am going to get us started and then we'll pull in Dr. Gary as we normally do. Generally, the layout for this is very conversational. We'll start off just with some basic information. I mean, my hope is that as we go through the discussion that there'll be a lot of audience input. As I said, I am here to share what I know, but also here to learn from the space and from this community to be a better advocate for patients and to be able to furnish better care from having my experiences with this group and otherwise. I have no disclaimers to make. In preparing for this conversation, I had an experience recently and I will share it, personal experience, but I will share it here. My family and I recently lost my grandmother. And one thing I've always said about grandmothers, grandparents, aunties is there's a kind of hug that they give you. And I call it the grandma hug. And with that, they fully embrace you and they kind of squeeze you up against their bosom. And right before you pass out, they let you go so you come up for air. As I've gotten older, I have really come to appreciate that. I've always felt that that embrace or that hug when it was done or when the moment passed, I felt lighter, whether it was emotionally, physically, or otherwise. And I had the pleasure of running into my grandmother's really, really good friend. By extension, she's also my grandmother. And she gave me one of those kind of hugs. And I sat in that a little bit longer this time because as my grandparents and family members are passing on, those moments become more and more sacred for me. And as I was getting ready for this talk, I was reminded of a paternal aunt who was diagnosed with breast cancer. And she was notorious and excellent for giving those kind of grandmother hugs, albeit she wasn't a grandmother, but she really delivered on those hugs. And I got to thinking she had a mastectomy. And as I was sitting there just thinking about her, and as I said, getting ready for this presentation, I wondered whether her embrace or her hug of her nieces, nephews, grandchildren changed after her mastectomy. So how did her self-image, body image change from post-diagnosis and post-treatment? And it is with that humility and appreciation for the journey for women who are going through breast cancer, have survived breast cancer, and plus ovarian or any of the other GYN cancers that I approach this and I serve this community. Now, the topic of self-image, especially amongst women who are living or surviving breast cancer, is wide and deep. So it's not something that I anticipate that we'll be able to get through and discuss and cover all bases with one conversation. But my hope is that we'll be able to cover what's important for the individuals in the audience, and definitely hopefully plan to be able to have a subsequent follow-up from this conversation. When we talk about body image, I tend to think about it with two domains. One is, how do I perceive myself? and how do I invest in myself and in my body image? And that will change depending on where in the life cycle we are, or where in the life cycle a woman is. So that I've taken care of patients who were diagnosed with breast cancer in their late 30s, early 40s, versus perimenopausal, postmenopausal women who have been diagnosed with cancer in their 60s, 70s, and what that journey for them looks like. I will take the premise of recognizing I will take the premise of recognizing that body image is not one domain, it's not one perspective. It's influenced by multiple factors, including society, culture, ethnicity, geographical location. And it's it's because of these multiple facets and lenses that it becomes such a broad topic, and it becomes such a deep topic to talk about. So again, I will touch on a little bit of everything, or try and touch a little bit on everything, and then look to the audience on participation and influence just to drive the conversation from there. Now, when I'm seeing patients as a general OBGYN, we may be the ones diagnosing the breast cancer before I refer the patient to Dr. Gary as a breast surgeon or the breast oncology team, versus I'm seeing them halfway through their journey. So they've had the diagnosis, they've recently completed treatment and are going through the surveillance period, or they've been 5, 10, 15 years out of the from their diagnosis and treatment, and the conversation will change. I work to meet the patient where the patient is in their journey. If I'm meeting a patient for the first time versus we did the diagnosis and we are walking with her on that journey, it's a different approach. So normally when I meet patients in the office, we'll have a conversation. Is this your annual well woman visit? Are there specific issues that are bringing you into the office? Again, I'll start with the different age groups. So if I have a 38, 40-year-old that we have came in, found a mass, went in, did the mammogram, and lo and behold, there's a mass there. There's a conversation that we have, again, with regards to, all right, we have this diagnosis, what are the next steps? Generally, it's a referral to breast surgeon, breast oncology. But what about the other parts of the woman's health? So one, we talk about fertility. What are my concerns? What are my child bearing goals? Am I planning for pregnancy anytime soon? Did we diagnose the breast cancer during pregnancy, or did we diagnose the breast cancer as I was looking or interested in addressing fertility preservation options? We also speak about sex and how that changes. Again, depending on if this was a newly diagnosed, it's a newly diagnosed event, sex tends to take a back burner, which is appropriate. And then I see her for follow-up post-treatment, and we can further discuss that. There's also, hey, I want to have children. I'm having children in the next 3 years, versus how does my cancer treatment affect my ability to nurse, lactation, other treatments? Do I have that option? I still want to breastfeed, but may not be producing enough milk. What does that look like? What are the options that we can offer women at that stage? And then say we have a 49-year-old female, perimenopausal, so she's beginning to go through the changes of life. And I'll stop for a moment and speak about the caveat for menopause. Average age of menopause in this country is 51. Some people may start experiencing the hot flashes, vaginal dryness, etc., 5 or 6 years prior to actually going through the 12 months without a period. So in addition to, I'm getting older, my body is changing, things don't look the way they did before, sex is changing. How then do we incorporate or work with the impact or the effects or the diagnosis of breast cancer? And then my 60-year-old patients come in, whether they've just been newly diagnosed or they're 5, 10 years out from diagnosis, treatment, and are going through the surveillance period. Yes, we're postmenopausal. We may have diabetes, high blood pressure, high cholesterol. I've had 3 or 4 previous vaginal deliveries. My organs are dropping. How do we manage that given the side effects of the medication or side effects of the treatment? And how do I work to address some of those concerns? Now, when I speak with patients, the 3 C's I normally talk about. So it's very common to have concerns with regards to the diagnosis or life after the diagnosis or life during the treatment itself. Number 2, identifying those concerns and identifying the priorities of those concerns and what are the consequences, number 3, of those concerns. And then working together with the patient, and if we need to pull in other support services in order to be able to get her the care that she deserves and needs. I'm going to pause for a moment and bring in Dr. Gary and see whether there's anything additional. Otherwise, we can talk about the different aspects of the impact of some of the treatments. So I'm talking about menopause, genitourinary syndrome of menopause, some of the options and guides that we use or will have patients utilize for things like pelvic floor dryness, physical therapy, etc.
I want to ask you again, what were those 3 C's? Because I want to make sure that we got those, because people are watching who may be caregivers and they may go with their friends to their appointments and things. And what were the 3 C's again that they needed to talk about with their doctor, or kind of ways to couch that conversation?
So number 1 is it's common. So recognizing and appreciating that it's common to have concerns about the diagnosis and the impact of the diagnosis and treatment. Number 2, what specific concerns they have. And number 3, what are the consequences of those concerns? So say, for instance, a woman is status post surgical management for breast cancer, and she's transitioning back into the workforce. And she was a specific size, clothes fit a certain way, and now all of a sudden, status post treatment, the fit is not the same. There may be weight gain issues, so that transition. So those are things that we discuss and talk about at the visit. So that's the 3 C's.
I love that, because the challenge that happens sometimes when people come to see me, the breast surgeon, one, it's like a bomb goes off and you hear, cancer, and everything else is just kind of mouths moving and you're like not quite catching all of it. And some people are like there and they got it and they're getting their notes, or they already took notes and they're, rolling with it. But a lot of times you miss things. And so it's not easy to name those concerns, because you're still trying to figure out what's an ER, a PR, and a HER2, or, what does this mean? And so I think that this is really good advice to think about in advance. If you happen to read your portal or something, or that you have an appointment coming up, is to not feel bad about asking these types of questions, and to normalize it. It is common to have them, and then write them down, or make sure you call them out before you walk out of that exam room. Like, really, hey, listen, I had a list of some things and I might have forgotten 1 or 2, but I got at least, 1 or 2 jotted down. And then what are the consequences? Because it's hard for me to get to the consequences part when you're still understanding the diagnosis part. Am I going to die? Do I need chemotherapy? What about my FMLA? What about that vacation I got coming up? Like, you're trying to figure out life stuff. And so the conversation about how surgery, or how all of this impacts your sense of self, your sexual self, your sense of your physical person in your body, like how are you going to feel in your body, sometimes takes a back seat. And I think it's really important for us as doctors to remember to have that conversation, but for patients to say and ask. It's okay to say, hey, listen, I understand you're saying you're going to do a lumpectomy, but how much are you going to remove? Or, what's that going to feel like afterwards? Or what should I expect? And so starting to ask those questions, because the studies show that, men are counseled about sexual dysfunction with a diagnosis of prostate cancer. About 80% of men, they have some conversation with their doctors about sex. 25% of women at best have any conversation about sex, about intimacy with a breast cancer diagnosis. And it's never from the beginning. It's always right around the time when you start taking a pill that makes your vagina dry and drops your libido. And then we start having that conversation. Everybody's trying to figure out what to do. And so I think it would be really helpful for us as oncologists, especially the surgeons, to do a better job. And if we forget, and if we're just trying to draw the pictures and explain the cancer, to stop and say, so might be a secondary thought, but not so much. What should I expect from this in terms of my, how am I going to feel in my body? And what about sex and intimacy, and normalizing that conversation, and don't let anybody make you feel bad about it, because I feel like we do that as oncologists. And sometimes when we say, well, how much volume am I going to lose? And you're like, well, listen, I'm trying to save your life. No, it's not just about that. Like, that's important, but those are legit questions to ask. So I really love that you brought up those 3 C's, Doc, and I guess the question I have for you is, do you get to see patients in the middle of their treatment and have these conversations a little bit and talk about, like, dryness and sort of libido and some of those concerns? Or is it mainly after everything has happened and the fallout, and then you have to pick up the pieces of the stuff that we didn't say, to women during that treatment time?
So normally, it's in the surveillance period, so 1 or 2, more closer to 2 to 3 years post treatment, or I'm the one making the diagnosis, and at that point, really, sex is not even on the front burner. But to your point with regards to things are changing, body parts, etc., I do make a concerted effort to review anatomy, and I think it's very important. And I think part of that, hey doc, there's issues from a sexual perspective, I'm concerned about my sexual health, is a patient's comfort with describing their anatomy. I feel like patients have a better idea or description, or know that this is the nipple, this is the areola, this is the underarm, and there may be lymph nodes here, versus when we get to the genital or groin area, it's down there. That's the space. That's the definition I tend to hear. It's down there. And also, especially for older women, some older women, and depending on cultural influences and ethnicities, just the sheer comfort of talking about sex. Now, I tell a lot of my patients, listen, if you can't talk to me about sex, we have a problem, because I take care of that area generally, right? So we go over the anatomy. When I talk about the vulva area, what are we talking about? So it's everything that when I have you in stirrups, this is the exam I'm looking at. It's about, okay, I'm walking you through what I'm doing as I'm doing it. I'm looking at the external genitalia. Everything looks fine here. I'm placing a speculum. I see the cervix. I'm looking at the vaginal walls. I don't see anything concerning. I may see something concerning. Talking about cervical cancer screening, etc. So for a woman to be able to identify, hey, I'm having dryness. Where is the dryness? Is it inside of the vagina? Is it on the outside? Is it just on the labia? I'm having itching. I'm having irritation. Again, localization is very important. And I've been known to pull out a mirror and say, all right, point where your concerns are, because I, as your physician, also need to be very clear on what the areas are of concern, right? So you may not be able to verbalize it as a patient, but you're able to point when there's a mirror in front of you, or just point, this is the area that I feel the pain, this is the area that I feel the itching. So patients being able to be comfortable discussing their anatomy goes a long way. And sometimes it's a 5-10 minute conversation, and sometimes we need to break down that conversation over several visits. It's tailoring the journey or the discussion and the evaluation to where the patient is. It can be a very overwhelming visit versus, okay, it's getting to be a lot of information all in one visit. Let's take a step back. We'll do this today. I'll give you some reading information, review it, write down your questions. We'll see you back in a week, and we'll have a more in-depth conversation.
I think that's really helpful. And I know, like, someone in the chat here, we're talking about sex drive, right? And we're talking about, just sort of understanding the changes that can happen. And it's really hard, I think, for you to be intimate with your partner when you are not so comfortable with yourself. Like I blushed a little. You said, put the mirror down there and take a look. And I was like, boy, that's really real. But it is, right? And if you can't even look at it, you can't tell somebody how to please you or what it feels like or what feels good to you. And I think that we magically expect our partners to know, and they don't. Right. And so I tell my patients, listen, when you get diagnosed with breast cancer, it's a bad time to get pregnant. Bad time for that, but it's a really good time to be intimate and to figure out what intimacy feels like to you, what sense of touch feels good, because maybe nipples are going to be sensitive, right? Maybe radiation causes a little bit of discomfort. Maybe you may not have nipples, you may not have breasts anymore, right? And so where are your erogenous zones, and figuring out some of those things and staying in that vulnerable space with your partner, I think can help you to feel more comfortable about this. And part of this too is self-pleasure. We should talk a little bit about that, Doc, because I feel like we can't expect other people to please us if we don't know what feels good to us, because then you and your partner get together every 3 months on date night, and it's like fireworks are supposed to happen, but they're wondering where to touch. It's like the first time, nobody knows what to do. And then you strike out and you're like, well, shame, blame, and pain. And so I tell my patients, give yourself 5 good tries, right? And maybe we're just going to start with just kissing and maybe a little touching until it feels comfortable, feels natural. Nobody says ow, nobody says oops, nobody says, things that don't go well with sex. And if you strike out the first time, you guess what, honey? We got 4 more tries at this. We're in this together, and it feels different. But I'm saying all to say something to be said for being able to identify the parts on yourself and have that comfortableness with your own body to say, oh, that doesn't feel good right there, or maybe I need a cream for that, or having those conversations, or even just looking down there with a mirror, because I don't think most of us do that generally.
That is true. I've met many a woman in her 60s and 70s who the first time they look down there is because I asked them to look down there with me as they guide me to the areas that they are experiencing discomfort or irritation. Um, Speaking on intimacy, it is important. Intimacy will change throughout a woman's life. So what I normally tell patients, whatever got you excited and working at 26, 27 years old is less likely to be the same thing that's getting you excited at 47, at 78 years old. And recognizing that and being comfortable with that is of utmost importance. I also encourage patients to move away from intimacy as just equals physical touch or physical engagement. With women who have not had sexual intercourse,
Uh-oh, I think we froze.
or have issues with painful sex. Are we back?
You're back.
Perfect.
Okay, perfect. So I'll go back because I'm not sure where I froze. For women who say haven't had sexual intercourse in many years, whether it was because of cancer or didn't have a partner and now have met a new partner and want to progress their relationship, intimacy will change. And as I said, I try to move away from intimacy equals physical engagement or physical interaction. Um, there's a lot to be said for maintaining clear and clean lines of communication, but intimacy could be something as little as let's watch a movie together. If there's a issue with vaginal lubrication, as we get older, things are not as quick as they used to be. So it may take a little bit longer to be fully aroused as it was, say, 10, 15 years ago. The best example I have is I normally tell patients, even in the heart of the winter, when it's really cold, you don't just get in your car and drive off. You have to warm up the engine. So similarly, you have to prime your partners or yourself. You have to prime the engine to be able to get it to a point where it can execute or it can fire accordingly. So the same thing, whether priming the engine could be maintaining lines of communication. It could literally just be dinner. We could be starting the foreplay on Monday morning for the event on Saturday, Sunday evening. So there's a progression, there's a patience that comes with that progression. There's a recognition and appreciation of intimacy outside of physical touch or physical engagement. It could be as little as, let's read a romantic book together, let's watch a romantic movie. Being able to redefine for yourself and or for the couple what intimacy looks like, especially during the current cancer journey, and not just GYN cancers, cancers in general, or chronic illnesses in general, becomes a very important part of sexual health and overall body image.
We got a question in the chat, and it's a really good one. Hot topic, ripped from the headlines here, Dr. G. Do doctors still shy away from estrogen-based creams for dryness? My understanding is that the estrogen is not systemically absorbed, so we should be able to use these. Your hot take?
Yeah. So yes, we are recommending estrogen, vaginal estrogen therapy for vaginal dryness. So I'll speak specific to the breast cancer, ovarian cancer, endometrial cancer population. If it's just the vaginal formulations, then that's fine. But if you may be getting oral estrogen, whether it's in pill format or patch format. With that, we do recommend, and this is general outside of breast cancer patients, we do recommend progesterone formulations, especially for women who have a uterus. But if it's just vaginal estrogen, you do not need progesterone supplementation. And we are using those even for women with breast cancer. If they're on tamoxifen, it's not an issue. However, if they're on aromatase inhibitors, there's a conversation that should be including the general surgery or breast surgeon and the oncology doctor, as well as the OBGYN and the patient themselves.
Yeah, I'll say from our side, we're still not recommending it, right?
Okay.
And so it's a last resort in the sense that if you've tried everything else, and by try everything else, there's a couple things. One, and I put in the chat, you got to do a moisture regimen because even as we get older and into menopause, right, we still need to moisturize our vaginas just like we moisturize our faces. Two, the libido issue can be a separate issue from the moisture, and then the lubrication is a separate issue from all of that. And so if you're still not having success after everything else, you've exhausted that, or you're having recurrent UTI symptoms because people can get recurrent urinary tract infections and things like that, then a little bit of vaginal estrogen is, it's better than living a life that is painful and sexless and, UTIs just to prevent your cancer from coming back. So it's not a first option for most oncologists, but we're getting better at believing the data because the data is out there and the data says that vaginal estrogen seems to be safe and the systemic absorption is low, although it's variable. What is a fingertip to you could be a dollop to somebody else. And I think that's
That
where
is
we,
true.
get into some challenges there. But I think in general, we're going to see over the next couple of years that more oncologists are saying it's okay. And again, for your quality of life and for your intimacy and all those sorts of things, I think we weigh the risk versus the benefits and just be honest with your oncologist. Say, hey, listen, you know what, my urogynecologist recommended this, or my gynecologist said this was safe. Here's what I'm going to do. I understand the risks, the benefits, et cetera. And they don't all know the data, so they might not all say yes, but there's good articles about it. Yeah.
Correct. And we may not always be comfortable, especially patient-specific information. We may not always be comfortable prescribing the estrogen, because that's the other thing, especially if there's a strong family history, increased risk of recurrence. So again, it's patient by patient. However, we too have alternatives. So I also have women who are like, no, vaginal estrogen is not an option. No hormones are an option. And we can look at water-based, silicone-based, oil-based. And we also have patients when all else fails, coconut oil, natural coconut oil, or olive oil have also been used, and patients have done very well.
All right, I got a question in the chat. We're talking about your look, right? The way you look might not be so appealing to your partner, et cetera. And my response was this, and unfortunately, a lot of this falls on the work of the individual instead of the partner, because it has to do with you learning your body and what feels good to you. And that means touching yourself, right? And masturbating and figuring out pleasure so you can help your partner know how to please you. Because most times they don't, and they didn't before cancer, and you were just maybe not that happy before even, and you didn't say anything before. So now it's like this process of exploring and figuring out what feels good to you, but now your body has changed. And so
Mhm.
while you could look to your partner to help to validate that, and the really great ones do, they love you, they see you no matter what, a lot of that has to come from the internal knowing that you're pretty badass and that you're gorgeous and that whatever it is about you that you really like is the best part of you is inside you and not on you, right? And
Correct.
so it's really hard to say that, and I don't want to trivialize it. So what I tell my patients is, if you can't if you have trouble loving yourself and appreciating the things that you don't like about yourself, then you have to shift your focus to something you do. So maybe it's your lips, maybe it's your legs, maybe it's whatever it is, maybe it's your butt. But every time you walk past the mirror, like, give yourself a compliment about that thing and start to shift your focus to complimenting yourself and saying nice things about yourself and building up your confidence about the things that you do feel good about, because it might not be your breasts anymore. Right. And so how do you get there if you're not getting that validation from your partner? It can be really, really hard, and therapy can help, but confidence looks good on every single woman, I guarantee you. And that is a really great place to start, I think.
Agree. And the other things I also talk about is nutrition, right? Regular exercise goes a long way. With regards to things like lymphedema, swelling, pelvic pain, we also have pelvic floor physical therapy. We also have osteopathic manipulative techniques that can help the lymphedema, edema, pelvic pain, um, facilitate or decrease the discomfort that goes with that. But absolutely agree with you, Dr. Gary, that the work has to start from within. And studies have actually shown that individuals who did not necessarily have great body image before the diagnosis of cancer tend to actually do a little bit worse with regards to body image or body issues post diagnosis and post treatment. So I am a big advocate of counseling, group support, team support, regular exercise, education, engaging with different individuals, and seeking out the services that you need to help you work on yourself, to help you feel better about yourself, especially given the drastic life changes on this journey.
Yeah, and for folks who are thinking, going flat and multiple scars, it's the part that we don't talk about. And I'm really sorry, because it's hard to, some plastic surgeons will treat reconstruction like it's a boob job, but most of us know it's not, right? There's nothing that takes the place, no matter, even if you keep your skin, you keep your nipples, all of it, it feels totally different. And I know my patients, some of them who have little scars right underneath, and they have their skin and their nipples, right? And they still have sex with their undershirts on in the dark, because
Hmm.
they just don't feel good about themselves and in that way. And so I said, try to find some clothes that feel good to you, that make you feel sexy, right? Like a nice satin cami, satin set, something that feel a little lace, whatever it is that makes you feel a little bit sexier to you, that can help to offset some of the what you see underneath that doesn't feel so good to you. Like how can you work around what you're not loving about yourself to understand that you still deserve to feel sexy. You still deserve
Correct.
to feel pleasure. Like, first validate that for yourself, and then figure out what makes you feel sexy again.
Hmm.
And if there is and go on that exploration together. Like, really commit to, I'm gonna find some cute bras, I'm gonna find some nice satin, pajamas, I'm gonna, whatever it is that makes me feel kind of like me again,
Correct.
and try to focus on those things, because the scars are going to be there, and even if you remove implants and you go flat, they're still going to be there. And then they may be a little bit worse. There may be some tightness, some range of motion things. So it's not just how it looks, it's how you feel about you, no matter how it looks. And again, not trying to trivialize it, but the look will change over time.
Correct. And to add on to the scars, so as an OBGYN, I also get to see the invisible scars, right? So the physical scars are a constant reminder, but the scars where the body is constantly remembers, even though it may not have any physical attribute to show for it. And here I'm talking about patients who may have had not a good experience, whether it was with the surgery or the pain from recovery. Patients who previously may have had history of sexual abuse, intimate partner violence, and how that shows up in the body during a GYN exam, whether it's inability to tolerate pelvic exams, inability to tolerate even breast exams, right? And as a physician and as a clinician, I work to be very mindful that if I've just met a woman or I'm meeting a woman for the first time who is ways into her breast cancer journey, permission to, can I do a breast exam? Because at that point, they're probably going back and forth between a breast oncologist or breast surgeon and myself. So seeking that permission, I know you probably already are getting your regular breast exams with your specialist. With this would breast exam would be part of your exam today. Would you like me to do one, or would you like to defer it to the specialist who's taking care of you? And that too is a conversation, and it's a place of comfort for the patient in knowing, I respect where you are in this journey. I respect the scars that you may not be ready to show, both physical and invisible.
Yeah, absolutely. I was just putting in the chat, not to discount things like visual stimulation, movies, etc., erotic writing. And it might be because for us, intimacy, especially, I know this conversation has really gotten around the sex, which is where it was probably headed anyway, but um, the act of becoming aroused is a mental act. It's a mental thing before it's ever physical. So it might be more sexting with your partner. It might be more reading erotic writing during the week that gets you prepared for whatever you and your partner have planned. And the build up for us is half the thing is the build up. For men, it's the act and they're good. But, I think that looking at ways to improve that communication, that sexual communication, could help. Yes, I see started chemotherapy, weight, right? Steroids make you feel all jittery and puffy and just weird in your body. And you're like up at 2 a.m. baking muffins and vacuuming. And it's just, I totally get how weird that is. And that part of it, resting, hydrating, making sure that you are spending a little bit of time, even if it's 10 minutes a day, doing something that feels like self-care for self. Like this thing is for me. Those are ways to start to reclaim a little bit of your sense of self so that you can feel just a little more confident, because no matter where you are in that journey, whether you're on chemo or out of surgery, radiation, or just recovering from it all, it's really challenging. We understand that it's a tough thing, but you have to start to chip away and nip away and bring some of that back to yourself and give yourself permission for that. And that's the first hardest step, is say, you know what? I deserve good sex. Like I deserve to feel, I deserve orgasms. I deserve to feel touched in ways that feel pleasing to me, and validate for yourself, despite what you're going through, despite how tired you feel, despite how steroids make you feel, knowing that you deserve it and that there are people who are doing it, but you've got to claw your way back a little bit. It's worth it for you.
I agree. And just going back to um, issues around sex. So I'm sensitive to peri and postmenopausal women who have prolapse. And that's whether it's the dropped bladder, the dropped uterus, the dropped rectum, and some of the challenges that those dropped organs may present during intimacy. Sometimes the women don't know, they just know something's dropped. There's sometimes an embarrassment or a shame that comes with that, such that they don't even mention it during the GYN evaluation. And it's not until I find it on exam, I'm like, okay, let's talk about this. Has this been an issue? And then that opens up the gate or the opening for, yes, let's talk about this. I've never really known what this is, but it has been impacting my sexual relations. Number two, urinary incontinence. And that's all, especially as women get older. There's been this adage for a long time where urinary incontinence is a normal part of aging. Now we're seeing research that is saying no, generally it's actually not, but it's not uncommon for women as they get older, or after having multiple kids, being engaged in activities for an extended period of time that require a lot of heavy lifting, increasing pressure and weight on the pelvic floor muscles, leading to urinary incontinence. The idea that, hey, I can't have sex because I leak urine during sex, right? So those are conversations that we can have with the patient as an OBGYN, and we can work to find solutions or ways to alleviate the discomfort or the self-awareness of something's not right down there. Prolapse is actually a very normal and common finding amongst women. However, they may not be comfortable discussing it. They may feel like, oh, I'm weird, there's something going on there. That is not the case. And I strongly, strongly encourage women to be comfortable and open enough to put things on the table and have those discussions, because there's some things that we encounter or we experience or we tolerate as women that we don't need to, or that we can find solutions for, temporary or permanent, to be able to alleviate some of these obstacles that we handle or we manage from a bodily perspective.
Yeah, this is such a great interactive chat that's happening over here. It almost makes me want to have you write down some more of your questions, and then let's do another Q&A where we can actually go through some of the questions that you have with some specific answers, with some links, with some things that can really help, because it's one thing to help validate and to talk about it and have a safe space to do so. But I know that people are, kind of struggling with some of this stuff, like the Benadryl and the steroids and some of the reconstructive questions and stuff. And I want to make sure that, I know we don't have enough time today, but make sure that we can get to answer some of these things. So maybe we could, Sue and Aaron, kind of have people submit their questions for another Q&A that is really focused on those questions too. And bring them, like, no question is off base, and
Correct.
we may not have all the answers, but we can definitely, oh, this one I can do. And all
Mhm.
right, so advice for preparing for a mastectomy mentally and emotionally. And you probably better asking these women here, but I can tell you from my surgical clinical perspective, one, recognizing and finding places of touch that feel good to you. And for a lot of people, it's small of the back. It's having somebody rub your back. It might be rubbing your shoulders, because this is going to feel weird. It's going to feel numb. It's going to feel achy, tingly, itchy, and a whole bunch of other things. And so finding places to rub and touch that feel good to you are important. Stretching, prehab, right? Doing as much as you can to stretch and lift to increase and improve your range of motion. Some people walk up the wall. I tell people to do this kind of stretching over here. You're watching Family Feud, like you're getting it in, and it's not like real rigorous stretching, but it's something to help to keep this expanding, because after surgery, it does this. Because it hurts, and we hurt you and we cut you and you do this, and your posture all of a sudden is going to end up looking like, I don't know if you can see my back, but it's like, it looks like the letter C. It's brought to you by the letter C. So posture helping things that are going to help you for that. The change, it's totally different. And when you normalize that and don't expect it to feel the same, that too is a help, because sometimes we set ourselves up for expectations that it's all going to feel exactly the way it did before. And, don't let any doctor tell you, no matter how great we think we are, it's very different. And you won't know until you get there. But the only way through it is through it. And on the other side of it, the people that love you, they see you, they know you, you're going to get rid of this cancer, and life will go on for you in that sense. And I'd say those are the main things, and hydrate really well. Eat lots of protein and lots of minerals, zinc, selenium, chromium, green leafy stuff to help your wounds to heal better. And ask about scars. If you keloid, if you get thick scars, ask your doctor about scar management early. And when can I start massaging scars? What creams do you recommend? How soon can I get back to whatever it is that feels good to you that you used to do before? So definitely ask those questions. We got a question about Lupron, tamoxifen and Lupron and AI and libido. Any tips, Dr. G, for libido?
Oh, that's a loaded question. So one, understanding that tamoxifen and aromatase inhibitors will give you postmenopausal symptoms that will make you feel like you're going through menopause, and that's because they essentially are blocking estrogen. With regards to, I'm sorry, I just lost the word. With regards to libido, Jenny, I don't. So when it comes to sex and sexual dysfunctions or sexual issues, I'm very cautious in my approach because I don't always want to say it's absolutely the medications that are doing this, and especially in patients with breast cancer, it's a lot. So we need to make sure that mentally everything is good, relationship-wise, we're healthy before we start focusing on specifically this is what we can do for libido, anorgasmia, etc. But yes, there's medications. FDA approved for the management of decreased libido. Filbanserin is one of them. The key with any kind of medication is being very cognizant of the risk of cross reactivity or drug interaction with other medications, but also the side effects. So medication like filbanserin, there was a caution placed on this drug with regards to alcohol consumption, right? So generally the minimized drinking or no drinking. I believe actually when they first came out, they had said there was a maximum of 2 drinks if you were going to use the medication. Side effects of this medication: fatigue, nausea, vomiting, GI issues. So it may not work for everyone, but a lot of the remedies and the options that we talk about with patients, it may take multiple trials of multiple different agents to be able to find the one that works best for you. And then, of course, with regards to the sexual issues, there's things also like for pain, vaginal dilators, self masturbation or sex for one. We talk about using toys, which can enhance lubrication, vaginal lubrication, the use of lubricants during intercourse, and the different kinds of lubricants. So there's a whole conversation on that when it comes to addressing issues with sex, whether it's arousal, orgasmia, desire, etc.
Yeah, and it's mental and it's physical, and teasing out the two and doing what you can do to control for some of the variables, making sure you're hydrated, well rested, looking at issues of pain, looking at, some of these other things that might be interfering with your ability to become aroused. Like, who can do it when you're exhausted? You might have been
Yeah,
able to use
that's true too.
things, right?
Correct.
But
It never works when you're
certain
exhausted
age,
because at that
right?
point you're just looking at the
Yeah,
time and like when do I get to sleep,
yeah.
or when do I get to figure out the next thing. So, and this is with all women, I'm like, when you're exhausted is not the time. When you're angry is definitely not the time,
And the
right?
question is, well, when are you not exhausted, right? And so that
Good
means you have
point.
to prep up to that, right? So that's why I say set your goals. Maybe your goal is like 2 weeks from now, we're going to be able to blah, 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 or I'm going to have a night with myself where I'm going to really figure some things out. And now you got 2 weeks to mentally psych yourself up. You got 2 weeks to try to rest up a little bit, hydrate some, get a little moisture regimen going, like give yourself some dates so that you can have a date with yourself. And
Correct.
don't make it like
Absolutely.
tomorrow, because then you're
Absolutely.
going to disappoint yourself and then you're going to dump your date, and you can't dump yourself. So there's that.
No, you
Mhm.
cannot. Please, let's not do
One date
that.
you can't
But
get rid of. No.
absolutely, absolutely. And I want to make sure I'm very mindful of everybody's time. Time check. We are 1 minute to 6 p.m. I think Dr. Mo's recommendation to take down the questions. I really haven't been following the chat. I've just been listening to Dr. Mo and going off of her reading the chat, but definitely open to having future discussions, going over the questions that we did not get to, or even the subject topics that we did not get to, and individuals are interested in getting more information.
Yeah, I agree. I gotta log off because my Black Doctor show is starting. We're talking to our interns today, and I gotta go log on to another Zoom. But I definitely want to do a part two. We'll get down to questions and more to come, and yes to a sex session. And I think this is gonna warrant an in-person session soon. We're gonna need to probably do something and
Yeah.
really get folks together where we can, in maybe a couple different cities, and figure out how to get people talking in person and sharing about this and feeling supported and trying on some good stuff and bring some props and boxes of tips
Yeah.
and things and
Yeah.
We like props.
lube samples,
we-
all of it. We're here for it. Yep.
Yeah,
Absolutely.
thank you so much. You both were incredible. There are definitely more questions to be answered. So Erin and I are going to actually take this chat. We will send you the questions, Dr. Mo and Dr. Gichuru, and then we will post the answers with the link to the recording. So that way everybody can actually get access to all these questions now in real time and don't have to wait. So if that's okay with you guys, we will do the ones that were not answered and put them up there. Even myself, I'm sitting here listening. I think a lot of you know, I am a 20-year survivor. I have went through so much of what is in the chat, and oh gosh, be gentle with yourself. It is, I remember those days. I remember the feeling of not being sexually adequate, available, able, capable, vaginal sores. I was a young woman, in my 30s, and I remember these conversations like yesterday. I am more than happy to talk to anyone who wants to reach out to me. I feel like I can help you at least talk through a little bit when you're asking about some of these questions too. I have gotten reconstructed 2 times. I have had capsulated implants once and had to get them switched out. I did do nipple tattooing, but waited for 9 years. Why did I do that? I don't know. They look beautiful. Such a difference. And just the look in the mirror made me feel like, oh, there they are again. I didn't get reconstructed for 4.5 years, went flat because I just did not care. And all of this was just a process, right? To get to where I am today. So I just feel like you got to give yourself time. It's a lot. The way you're feeling, it's valid. You should feel all of it because you are going through a difficult time. It is traumatic, and do not feel like you should not feel any of these emotions. It is important that you end up feeling like you can gain that control again, gain that confidence again, one step at a time. And that is why we had the Unite for Her program. If you look in our library, we have done a lot with sexual health, sex and intimacy, dating. We have a lot of resources. We have, I popped a couple in there. Anna Ono is amazing I bought my first bra after mastectomy 9 years later from her. I was not wearing anything. And then all of a sudden I'm like, oh, I feel better. It was a journey. It took time, and there are resources out there. That's why you can rely on us and our community to help you through. The same thing with Good Clean Love. I had no idea that moisturizing should be a daily thing. That would help you. It helped me. It helped me for so many reasons. And that friction and intercourse and thinking about the things that Dr. Mo said about intimacy does not have to be just intercourse itself. It can be so many other things. I have gone through all of these emotions, and they all are valid. So know that we have a lot in our library. We would love to bring back Dr. Gichuru and Dr. Mo. They're just dynamic. I agree. You should all have doctors like them and not settle for less. And that's where I feel like ask the questions. You're tooled now. You came on tonight with us. You have this ability to make it more open and normalized to talk about things that are bothering you. But know that you can ask us, right? We are your sounding board. We are your safe space. You don't feel like you have to always talk about it with your family and your friends. And you can save those conversations for things that you just want to talk with joy and love, and give us the heavy stuff, because we'll carry that for you. We will help you. And we have resources that can do that as well. So I don't know. I feel like I was holding all that in the whole time. I was
So that
listening
was
to so
great. That
much.
was
Oh gosh,
great.
I just remember it all. I remember it all. And I just want to say you will get through. You will get through. It may be different. It may look different. It's okay. It's okay if it's different, because you will gain confidence, you will gain control, and we will help you get there. And we have incredible, incredible resources to do so. So, okay.
So the only thing I wanted to add is I co-sign everything that you said, extending yourself the time and the grace. And I have to really emphasize the grace part, because with going through this journey is not easy. There's challenges both from a physical, mental, spiritual perspective, but grace will get you there, and grace will get you through it.
Thank you. I cannot agree more. I want to hug each and one of you. I want to give them your grandmom hug. That's what I want to do with my reconstructed chest that I have, and not think twice about it. And I cannot agree more. So Jennifer was saying, does the session use Passport Square? So we have sexual health counselors that actually will do like counseling sessions with you in sexual health one-on-one that can use your squares. As far as the education series and everything that's on our library, no, all free, all about giving you education and that you can utilize at any time, just popping on. But we do have private ones that we have available for you with our advisors and our counselors available in sexual health. So that's something that you can do. But yeah, I'm grateful for this topic. I'm grateful that you took the time today, Dr. Gichuru, and I just my heart goes out to all of you. I know all too well and what you're feeling, and it is real. And I remember the first time I gave myself grace, as you said, it was my acupuncturist. And I remember the day. I'm going to get filled up thinking about it. I was in acupuncture. It was in October. I started my chemotherapy in May. I never cried. I had 3 little kids, and I came in very depressed and filled with stress and anxiety and what was my future looking like. I did not get reconstructed. I didn't even know what I wanted to do. And he told me, Susan, you have every right to feel depressed. If you did not feel that way, that would not be normal. That would not be a normal response. And you should not try and cover that up. You have gone through a trauma. So let's meet you where you are, one step at a time, and get you through. And that's what we did. One step at a time, 1 month at a time, and finding resources, finding a little yoga, finding nutrition. It wasn't one magic bullet, right? And those conversations with your loved ones, your partner, they come, one step at a time too. And it just was valuable. It was valuable for me to give myself grace, And that's what I wish for all of you tonight, is to give yourself grace. Yeah. Okay. The tough one.
Yeah.
Tough one. Yeah.
But I think we're getting lots of thanks for just sharing your vulnerability and your experience, and just sharing that validation from a lot of members that are here of your experience. So
thank you. All right, we have more topics coming up actually on this subject as well. So just keep your eye on our education series. We bring a lot to you. Please go back to our library. There are a couple that we've done with sex and dating, sexual health, body image, and Dr. Gichuru, we're going to give you a little bit of a list of questions, and we're going to add them to this recording so that way you guys will get that in real time. Okay.
Perfect. Thank you very much.
Thank you.
Wonderful.
Have a good evening.
For that visual of that hug. I am going to keep that with me. I love it.
I love that.
Perfect. Thank you. Take care and have a good evening.
Thank you.
Bye.
All right, Erin, thank you for everything that you do to bring these education sessions to the community of Unite for Her. We are so grateful once again to our sponsors, West, Merck, Daiichi Sankyo, Lilly, and GSK. We cannot do what we do without them. Tonight was very real. We appreciate you. We appreciate everybody who hung on with us. We had a big crowd tonight, and we are here for you. And you can call and reach out to me anytime. Yeah.
Wonderful. And hopefully we'll see you next week for our Ask the Experts, just to round out April. But this segment, if you want to go back on and rewatch or share with anyone, it'll be on our library as early as tomorrow. So, so hopefully you'll be able to check that out, and as well as our other sexual health segments as well.
Yep. Perfect. I'm going to put my email in the chat just to finish up. And everybody have a wonderful evening. Thank you for joining us.
Thank you, everyone.
You're welcome.